illustrative video of microsurgical management of large colloid cyst third ventricle, transcortical circle, transventricular navigation guided excision. This 26-year lady presented with worsening headache of 3 months, swaying while walking and double vision. Examination showed vasopressor score 15, she had ataxia, bilateral sixth paresis. She was investigated with CT scan brain, the periphery, and sent over to us for further management. We investigated her with MRI scan brain. CT and MRI scan brain showed a large third ventricular colloid cyst, size about 3 centimeters by 2.8 centimeters by 3 centimeters, located inside the third ventricle, more onto the right side, going superiorly into the lateral ventricle through the midline, gross ventriculo-megaly. Colloid cyst third ventricle management was first begun by Professor Walter Dandy, 1920, with the precoronal transmid-frontal gyrus transventricular transabdominal Monroe approach. In 1940, he gave transcallosal transventricular, which is practiced all over the world today. We modified his first technique, which was done 1920, by going through the inferior frontal gyrus and sulcus and accessing the ventricle through the navigation assistance and complete excision of the lesion. Transforaminal axis. Navigation is of great help in these cases. It gives us the dimension of the cyst, location of the cyst, safe, comfortable, quick access to the frontal horn, ventricle, foramina Monroe and the cyst, and minimizes the surgical morbidity. These are the steps of navigation planning. The access point on the forehead, just above the orbital roof, is planned, and the ventricular axis is planned. That's a point of entry. On that, the frontal basal paramedian craniotomy is done, a pedicle flap on the temporalis muscle, and the dura mater is opened with the base towards the midline. The frontal cortex, basal frontal lobe is exposed. We select the inferior frontal gyrus, mid and lateral part. Again, with the navigation assistance, we access the frontal horn of the lateral ventricle. This is the direction and depth of frontal horn through the navigation assistance. Following that, the sulcus is open about 1 to 1.5 centimeters as shown here, and keep widening the entry point and deepening the entry point. The white suction, what we are seeing is navigation active suction, which is available, is of great help. It gives us a live navigation during the access so that we don't miss the track and we keep going. That helps in minimizing the access point and precisely takes us to the frontal horn. Now you can see the ependema is open. We have reached the frontal horn of the lateral ventricle. Once that is done, the access point is covered with the wet cotton and hemostasis is achieved so that the blood from the access point should not seep into the ventricle. Once that is confirmed, you can see the suction, navigation suction pointing and showing us the location of the cyst. With this axis, the cyst is accessed in less than about 15 seconds. The cyst will be directly looking at us and we are looking at the cyst. We don't have to keep searching for the foramen Monroe and the cyst in third ventricle with this axis. If you don't have a navigation, it's also fine. You can use a brain cannula and follow it to open the get the access to the ventricle. Once that is done, you can see the foramen Monroe and the cyst directly looking at us on the surface. There is a choroid plexus of third ventricle which is coagulated, and usually these colloid cysts will have two capsules. One is low capsule by the arachnoidal membrane, and second one is a true capsule. Unless we cut open the arachnoidal membrane, that is a slow capsule, we cannot excise these cysts inside the third ventricle. Now the arachnoidal layer is cut and the true capsule is exposed and arachnoidal membrane is separated. With a fine hook, the arachnoidal membrane or sugar capsule is separated all around the cyst surface of the cyst wall. Superiorly, the cyst gets adherent to the fornix, anterior body and crest of the fornix or tail of the fornix. That you need to remember. Once that is done, gentle dissection is started inside the third ventricle. Always we need to use under high illumination and high magnification. The cyst here gets the blood supply from the choroidal anterior choroidal artery and the branches, the subependymal vessels, capillaries, and these vessels on the surface of the cyst, if the cyst is large, will be quite extensive. At this juncture, always proceed with coagulation on the surface of the cyst and coagulating the vessels, which will help us preventing the bleeding during the dissection, keeps the operating field very clean. At the same time, it helps us in shrinking the cyst size inside the ventricle. That is a venous drainage of the cyst which goes into the subependymal and ependymal veins, septal vein, thalamus vein, which is coagulating. Now you see the adhesions between the fornix and the cyst because of the chronicity. These are arachnoidal adhesions from the capsule, which needs to be dissected and cut with the sharp dissection. You cannot pull them. If you pull them, they start bleeding. So with the sharp dissection and at high illumination, high magnification inside the third ventricle, we need to keep separating the cyst from the third ventricular wall and keep it separating it as shown here. Now we have separated the superior wall. Now we are separating the anterior wall. Now you can see we are seeing the opposite foramen Monro there and the choroid plexus from the opposite foramen Monro third ventricle, again attaching or adherent to the cyst wall. Again, that needs to be correlated. These are the factors which cause bleeding during the excision of this cyst, and we need to have advantage of microsurgery with the bimanual smooth dissection, coagulating the vessels and the choroid plexus on the surface, which helps us to maintain absolute clarity and clean feeling. Now we have separated the opposite side. Ipsilaterally, inferior part of the cyst wall is being separated. You can see again on the surface there are blood vessels, venous drainage from the cyst going into the ependymal and subependymal veins. They are coagulated and reduced in size. Usually these cysts originate from the superior and posterior wall of foramina Monro. That part we need to keep it in mind. And there we have a lot of dense adhesions and more vascularity of the cyst coming from the anterior choroidal artery, subependymal and ependymal branches. They need to be coagulated. Now we are going deeper and deeper into third ventricle and separating the wall of the cyst from the surrounding third ventricle and the fornix and the third ventricular walls, lateral wall, anterior wall, and inferior wall. The excision of the cyst in these cases needs to be complete. Definition wise, it is the cyst wall with the cyst contents needs to be excised completely to prevent a long-term recurrence of this. Any small part of the cyst wall left behind may cause recurrence in the long run. So excision of the cyst wall along with the contents is a definition of complete excision of the cyst, which we need to do it under any circumstances. Now you can see we are going deeper and deeper into the third ventricle. That is the surface of the cyst with blood vessels supplying the cyst wall. They are very small, but if you don't coagulate them, they start bleeding. And the field, the operating field here is about 1 square inch. Needs to be kept very clean because we are operating at a very vital structure in the brain, deep core brain, central part of the brain, just very close to the hypothalamus and thalamus, basal ganglion, and internal traction. These facts and the limbic system, these facts need to be kept in mind, and we need to be very clear and achieve hemostasis and keep the anatomical clarity during the excision. Now, the deeper part of the cyst is being separated. We have reached the venous angle on the opposite side of the cyst, that's on the left lateral wall of the cyst, where the venous angle is usually formed by septal vein anteriorly, thalamostriate vein mid part, and the posterior cerebral vein, which goes behind by joining these two, drains into the deep venous system of the brain and into the vein of Gallo. These venous structures, under any circumstances, need to be preserved during the dissection, and they should not be injured. The deficits occurring during the post-operative phase are because of the injury to this venous system. Now, once that anterior part, superior, inferior part, and deeper parts are separated, now we are going into the superior and posterior part of the cyst, which is going into the lateral ventricle in the midline and more over the right side. Now, the surface of the cyst, again, the arachnoid covering is open superiorly and posteriorly, and posterior and superior wall is gently separated inside the third ventricle. The cyst has the thalamostriate vein and septal vein on the surface on the right side. They need to be preserved under any circumstances. Once the posterior and superior part of the cyst is separated, again, this cyst wall is dissected freely from the ipsilateral, that's on the right side, thalamostriate vein and septal vein, and separated by surface coagulation and remaining in the plane of the arachnoid, that is pseudocapsule. These are the surface vessels which need to be coagulated at early stage. That helps in keeping the area clean and preventing the hemostasis. Here, only the surface of the cyst is coagulated, not any vein or vessel away from the cyst wall, apart from the cyst wall. Only the cyst wall needs to be dissected, and surrounding vessels should never be injured or coagulated. You need to do this under high dimension, and the cyst is separated posteriorly, superiorly, deeper part, and that's a deeper adhesion of the cyst wall into the deeper part of the third ventricle, that is dissected and cut. Cyst wall is separated. Now you can see the blood supply coming from the anterior caudal artery onto the left side, supplying the cyst wall. That is dissected under high illumination and high magnification and divided and cut. Cyst is separated completely inside the third ventricle. Anteriorly, you can see the adhesions to the fornix is again divided and cut. Now the whole cyst is separated inside the third ventricle in one piece with the cyst wall, and cyst contains the whole cyst is in one piece. Area is washed clean with saline. Now you can see the microsurgical anatomy of the third ventricle. Opposite side, you can see the anterior septal vein from the left side on the left lateral wall of the third ventricle, thalamostriate vein, venous angle, and deep cerebral vein. That's the fornix, crest of the fornix, body of the fornix, and anterior fornix, venous angle, and absolute hemostasis is achieved. And the tract which we accessed to access the lateral ventricle frontal horn is covered with surgicel. And at this juncture, we request the anesthetist to increase the blood pressure by 30 to 40 millimeters of mercury, so that we don't miss the intraventricular bleeding points. We bring in the endoscope and confirm the comprehensive completeness of the excision, hemostasis, venous anatomy, and the arterial anatomy, and any injury to the ependym. Nothing appears to be there. Fornix is well preserved, venous angle is well preserved, and the ventricle is well preserved. This is the access point, 1.5 centimeters by 2 centimeters, access into the frontal horn of the lateral ventricle. Ventricles are filled with saline, and see that there is no bleeding inside the ventricle. This is the access point at the base of the brain, base of the skull, just above the roof of the orbit, 1 centimeter. Now we can see optic nerve there and superciliary structures. Brain is lax and pulsating. Dura is closed with the pericranial graft. Bone replaced and scalp closed in 2 layers. Same day evening CT scan then shows the track of excision. Cyst excised completely, no hemorrhage, swelling, edema, ventricles are reduced in size. This is her post-operative clinical status on day 2. Glaucoma score 15, no deficits. Her sixth nerve paralysis has completely improved. On day 5, she goes home independent without any deficits, and I am perfectly normal. This is our neuroanesthesia team, treating physician and neuro rehab team. Our presence online with more than 645 microsurgical, exoscopic, endoscopic, navigation guidance, educative neurosurgical operative procedural videos on our YouTube neurosurgical educative video class. Thank you very much for viewing.